ميلادي يا سنة الفجر
وينبوع الشذا العطري
ميلادي يا سنة الفجر
وينبوع الشذا العطري
وملهمتي أناشيدي وآيات من الشعر
سلام عند ألحاني وحلمي بالهوى العذري.
Welcome everyone. My name is Dr. Haitham Mekawi, and in this session we will explore one of the most challenging emergency situations faced today in Sudan: airway management in respiratory diphtheria. Diphtheria, a disease once nearly eliminated by immunization, has re-emerged because the structures that protect communities, hospitals, vaccination programs, and supply chains have been shattered by war. This lecture is not only about the techniques of securing an airway. It is about understanding how conflict magnifies risk, delays care, and places children and clinicians in situations where every second matters. Together, we will walk through the disease, the airway challenges, the collapse of vaccination coverage, and the realities of working in refugee camps and war-damaged health facilities. Diphtheria has returned to Sudan, not because the organism has changed, but because the environment around it has become dangerously fragile. Routine immunization has collapsed in many areas. Cold chain systems have been destroyed, health workers displaced, and entire regions cut off by fighting. In densely crowded shelters and camps, where families share limited water, food, and medical care, respiratory infections spread rapidly, and diphtheria finds the perfect conditions to flourish. The disease, once rare, now quietly moves through communities weakened by hunger, displacement, and loss. As clinicians, we must be prepared to detect it early and respond decisively. To understand diphtheria airway management, we must first understand the enemy we are facing. Corynebacterium diphtheria produces a powerful exotoxin that kills epithelial cells lining the airway. These dead cells, combined with fibrin and inflammatory debris, form the thick, gray-white pseudomembrane that diphtheria is known for. This membrane adheres tightly and extends downward towards the larynx and trachea. Any mechanical disturbance, even gentle suctioning, risks dislodging it, causing acute obstruction of the lower airway. Around this, severe soft tissue swelling develops. In children who naturally have narrower airways, even slight swelling can produce life-threatening obstruction. This is not a simple infection. It is a dynamic, toxin-driven, structurally destructive process in an airway that is already fragile. How war made the airway more dangerous? The war in Sudan has changed the clinical landscape in ways that directly increase the danger of every diphtheria airway we encounter. In normal circumstances, diphtheria is already a high-risk disease. The pseudomembrane, the swelling, the fragility of the airway, these factors alone make intubation delicate and unpredictable. But in a war-affected health system, this danger is multiplied many times over. How war made the airway more dangerous? The war in Sudan has changed the clinical landscape in ways that directly increase the danger of every diphtheria airway we encounter. In normal circumstances, diphtheria is already a high-risk disease. The pseudomembrane, the swelling, the fragility of the airway, these factors alone make intubation delicate and unpredictable. But in a war-affected health system, this danger is multiplied many times over. The war has also destroyed the vaccination system, leaving thousands of unprotected children vulnerable. Cases that would have been prevented by the DTP vaccine are now presenting late, unstable, and dangerously hypoxic. All these factors, delayed presentation, lack of equipment, staff shortages, no ICU capacity, poor monitoring, unstable oxygen supply, combine to create a scenario where every minute matters and every airway is a race against time. Understanding this context is essential. The danger does not only come from the disease, it comes from the environment in which we are now forced to manage it. When to intubate in diphtheria, deciding when to intubate a child with diphtheria is one of the most delicate and high-stakes judgments we make. Intubation in diphtheria is not like intubation in any other upper airway disease. The pseudomembrane is fragile, highly vascular, and firmly adherent. Touching it can cause bleeding, airway obstruction, or complete loss of the airway. Waiting too long, on the other hand, may leave us facing a child in full respiratory arrest with no access to a safe glottic view. So the question becomes, when is the correct moment to act? There are several critical indicators that should immediately raise alarm. A child who is drooling, unable to swallow, or sitting upright and leaning forward is already demonstrating significant airway compromise. Audible stridor at rest, especially when accompanied by chest wall indrawing, is a clear sign that the airway is narrowing and will deteriorate rapidly. The presence of a very large pseudomembrane, bull neck swelling, a muffled voice, or repeated episodes of cyanosis should prompt immediate preparation for intubation, not later, not after review, but now. But the decision is not based solely on the child's clinical appearance. The context of war must also inform our threshold. In a functioning hospital system, with an ENT surgeon available, an ICU bed ready, backup oxygen supplies, and full monitoring, we might attempt careful observation. In a war-affected setting where oxygen may fail, where there is no ENT backup, where transfer to ICU may take hours, and where deterioration often happens suddenly, the threshold for intubation must be earlier. When we're deteriorating, we must also consider the time delay caused by families traveling from conflict zones or refugee camps. Many of these children have been symptomatic for days before reaching us. Their airway may already be heavily oedematous, their pseudomembrane larger, and their work of breathing unsustainable. Therefore, the decision to intubate must be proactive, not reactive. It must be made with an understanding of how diphtheria behaves, how rapidly deterioration occurs, and how limited our options may be once the airway collapses. The priority is simple: secure the airway before the airway secures the child's fate. Before any attempt at intubation in diphtheria, there is one rule that outweighs all others: keep the child calm and avoid crying at all costs. In diphtheria, distress is not simply uncomfortable, it is dangerous. When a child becomes frightened, their breathing rate increases dramatically. This increased airflow causes the already fragile pseudomembrane to flutter, shift, or shear. A single tear can produce bleeding, release membrane fragments, or precipitate complete airway obstruction in seconds. Crying also increases negative intrathoracic pressure. In a swollen and narrow airway, this can collapse the lumen further, worsening stridor and pushing the child into acute respiratory distress. For this reason, we avoid anything that might escalate the child's anxiety. We keep the child with their caregiver, usually their mother, positioned upright on her lap. We allow the child to maintain their natural posture, often leaning forward, chin extended, because forcing them to lie back may lead to immediate deterioration. This is not the time for repeated examinations, unnecessary mouth opening, or attempts to visualize the membrane. The more we disturb the airway, the higher the risk of provoking a crisis. Our role at this stage is not to examine but to observe, stabilize, and quietly plan. We also minimize staff around the child. One clinician, one caregiver, and one assistant are more than enough. A crowded room increases noise, fear, and the likelihood of sudden agitation. Analgesia and sedation must be used with extreme caution. Any agent that depresses breathing, reduces airway tone, or alters consciousness can turn a partially obstructed airway into a completely obstructed one. In most cases, we avoid pre-sedation entirely and preserve spontaneous ventilation until the final moment of intubation. In war-affected hospitals and field clinics, this principle becomes even more essential. The environment is often chaotic, crowded wards, noise from generators, distressed families, and limited staff. A calm, controlled, focused atmosphere around the child is therefore a deliberate act of clinical leadership. Preparing a child for intubation in diphtheria is not a technical step, it is a human one. It requires empathy, quiet confidence, and teamwork. When the child stays calm, the airway remains open. When the child cries, the airway closes. Our goal is simple: preserve spontaneous breathing, protect the airway from trauma, and guide the child safely toward a planned and controlled intubation. When we make the decision to intubate a child with diphtheria, the next crucial question is where the procedure should take place. In this disease, the environment is as important as the technique itself. Intubation must never be attempted casually, hurriedly, or in uncontrolled surroundings. The airway is fragile, the margin of safety is thin, and a single wrong move can transform partial obstruction into complete collapse. This means we must deliberately select the safest location available, a place where we have equipment, team support, and a fallback plan. In ideal settings, the preferred location is the operating theater. The lighting is optimal, suction is reliable, airway instruments are available in full range, and the team can mobilize quickly. ENT support is usually close by, and a surgical airway kit can be deployed without delay. But war changes everything. Many hospitals in Sudan today have damaged theaters, unreliable electricity, or no access to an ENT surgeon. Some facilities have lost their entire pediatric equipment sets. In these situations, we must adapt. If the operating theater is unavailable, the next safest location is a dedicated pediatric critical care bay, ideally within an ICU or high-dependency unit. This space should have oxygen cylinders ready, working suction, capnography if available, and enough room to position staff without crowding the child. In some field hospitals or refugee camp clinics, the best option may be a stabilization room where oxygen, suction, and minimal monitoring can be brought together. What matters is not the name of the room, but the readiness of the environment. Wherever the procedure takes place, ENT support is essential. In diphtheria, the risk of sudden membrane dislodgement or complete airway obstruction is high. A rigid bronchoscope, tracheostomy set, and someone skilled in using them should be physically present, not on the way. Before moving the child, we assess the risk. A child with severe stridor, inability to lie flat, or severe work of breathing may not tolerate transport. In such cases, we may need to bring equipment to the bedside rather than bring the child to the equipment. Team briefing is also essential. Everyone must understand the plan: who is managing the airway, who is positioning the child, who controls suction, who calls for help, and what the fail-safe steps are if the airway collapses. Choosing the correct environment is not a luxury, it is part of airway management. In diphtheria, the battle for the airway is won or lost before the laryngoscope is even lifted. When the right space, the right team, and the right equipment come together, the procedure becomes controlled rather than chaotic. And in a health system shaken by conflict, creating this safe space, even if improvised, becomes an act of clinical leadership. It is how we protect the child, protect the team, and maintain the dignity of care in the middle of instability. Intubating a child with diphtheria is one of the most delicate procedures in emergency airway management. This is not a case where strength, speed, or force will save the day. In diphtheria, the airway behaves like a thin layer of ice. Any pressure, any careless movement can cause it to break. Once the pseudomembrane is disturbed, bleeding, obstruction, or total airway collapse can happen instantly. We don't all struck and happen instantly. Our approach must therefore be slow, controlled, and intentionally gentle. We begin by maintaining spontaneous ventilation throughout the preparation. Losing the child's natural breathing before the tube is in position can turn a difficult airway into an impossible one. Whenever available, video laryngoscopy is the preferred tool. It allows us to stand slightly further back from the airway, reducing the risk of contamination, and provides a magnified, wide-angle view of the laryngeal structures. This improved visual field is especially important because swelling can distort the anatomy and push the epiglottis into unusual positions. Wei introduced the laryngoscope blade slowly, avoiding unnecessary contact with the pseudomembrane. If the membrane lies on the tonsils or posterior pharyngeal wall, we do not attempt to lift it, remove it, or suction around it aggressively. Any disturbance risks releasing fragments into the lower airway. Suction, if used, must be minimal, brief, and targeted only to remove loose secretions that impede visualization. We then select a smaller endotracheal tube than usual. The airway is swollen, narrowed, and unpredictable, and a standard-sized tube may simply not pass. A half-size reduction is often necessary, sometimes a full size. With the glottis in view, we advance the tube slowly, watching carefully for any sign of membrane movement. If the tube brushes against the membrane and causes it to lift, we stop immediately. Pushing forward in this moment may cause complete obstruction. Once the tube is in place, we confirm positioning with waveform capnography whenever possible. Chest rise, auscultation, and misting are valuable, but in an unstable environment, especially a war-affected hospital with limited monitoring, capnography remains the most reliable indicator of success. We secure the tube firmly. Children with diphtheria often require prolonged ventilation, and accidental extubation in such a swollen airway can be catastrophic. Tape, cloth ties, or improvised fixation must be applied carefully but securely. Throughout the procedure, communication is essential. One clinician controls the airway, one manages suction, one monitors the child's breathing pattern, and one stands ready with the surgical airway equipment. In settings affected by war, where equipment is limited, oxygen supply is unstable, and backup help uncertain, the intubation technique must be even more deliberate. We do not get a second chance with the diphtheria airway. The first attempt must be the best attempt. This is not just an airway intervention, it is an act of precision, patience, and respect for a disease that gives us almost no margin for error. In severe cases, fiber optic intubation may be the safest option. It allows controlled navigation around swollen structures with minimal disturbance of the membrane. FOI is especially valuable when the laryngeal inlet is narrowed but still visible. However, FOI in children requires skill, cooperation, and a quiet, controlled environment, which may be difficult in conflict settings. Awake intubation is reserved for exceptional situations where sedation would cause immediate airway collapse. It must only be done by experienced clinicians with ENT on standby for an emergency surgical airway. These techniques are life-saving, but they must be planned, not improvised. When managing a diphtheria airway, protecting yourself and your team is just as important as protecting the patient. Airway procedures generate infectious droplets, and diphtheria spreads easily through close contact. Every intubation must therefore be treated as a high-risk exposure. The minimum protection is an N95 or FFP2 mask, goggles or a face shield, gloves, and a long-sleeved gown. Only essential staff should remain in the room to reduce exposure and maintain a calm environment. After the airway is secured, PPM must be removed slowly and in the correct sequence. Most infections occur not during the procedure, but during rushed or incorrect removal of protective equipment. In war-affected hospitals where infection control systems are limited, discipline in PPE use becomes even more important. Protecting healthcare workers ensures that care can continue, especially when the system is already under extreme strain. Once the tube is in place, the real work begins. Children with diphtheria remain at high risk even after successful intubation. Airway swelling often worsens in the first few hours, and membrane fragments may obstruct the tube. Humidification, gentle suction, and continuous observation are essential. Antitoxin must be given immediately because it stops further toxin activity, although it cannot reverse damage already done. Antibiotics such as erythromycin or penicillin should follow without delay. We must also monitor closely for myocarditis and arrhythmias, which are common and can be fatal. In a fully functioning ICU, this is challenging. In a war-damaged hospital, it requires constant vigilance and teamwork. Finally, the tube must be secured firmly. Accidental extubation in a swollen diphtheria airway can be catastrophic, especially in environments with limited equipment and few trained staff. Post-intubation care is therefore not passive. It is a continuous active process of protecting the airway, supporting vital organs, and compensating for the gaps left by a health system weakened by conflict. In diphtheria, the airway is not simply a clinical challenge. It is a race against time. When conflict destroys vaccination programs, weakens hospitals, and displaces families, diseases we once controlled return stronger and deadlier than before. Every child we treat in these conditions reminds us that prevention is always more powerful than any airway technique. Immunization saves lives long before we reach the bedside. And yet, even in the hardest circumstances, clinicians continue to stand between danger and survival. Your skill, your calm, and your refusal to give up make all the difference. As we move forward, let us carry 3 responsibilities: to protect ourselves so we can continue to protect others, to fight for vaccination access, even in times of war, and to approach every diphtheria airway with precision, patience, and respect. Thank you for your attention.